Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent medical education grant from Regeneron Pharmaceuticals, Inc. and Sanofi.
Hi, Sadie. Good to see you again. How are you?
Oh, all right, I guess.
I see here, based on the questionnaire that you filled out for us about your COPD symptoms, that it seems like your symptoms are getting worse.
Yeah, my breathing has gotten worse and I cough a lot more now. I'm thinking it's probably just my age.
Okay, well, let's see what's going on. Since I last saw you 10 months ago, how many flare-ups have you had? By flare-ups, I mean visits to the ER or urgent care or times you needed antibiotics or steroids.
Well, 6 months ago, around the holidays, I ended up at the urgent care for a cold and they prescribed steroids. And then about a month ago, I had to go again for a cough and they gave me antibiotics.
Okay. Tell me about your everyday activity. Are you still working?
Yeah, I'm still over at the department store. I restock in the evenings.
How's that going? Are you able to keep up with your tasks as you did before?
Honestly, I feel like I'm falling behind a lot more lately. I just can't seem to work as fast as I used to. And I need to sit down more often to catch my breath.
What about at home and just everyday tasks? Are you able to keep up the way you used to?
Well, it's definitely getting tougher. I watch my grandbabies during the day so my daughter can work. Those kids run me ragged. I used to take them to the playground and run around with them. Now I get winded just walking over to the park. It's frustrating for me, but I guess I'm just getting old.
I understand you had a recent visit to the cardiologist.
Yeah, I just wanted to make sure everything was okay. The doctor said all my tests looked fine.
Okay, I'm glad to hear that. I wanted to ask you about your smoking. Last time you were here, you mentioned you were 7 cigarettes per day when you were trying to cut down. How's that going?
All right, I guess. I'm down to about 5 per day, depending on the kind of day I've had.
Okay, that's good. You're making progress.
I'd like to do better, but I'm just so stressed with everything, and it just relaxes me to have a smoke.
Yeah, I get it. I understand that things have been stressful for you, but quitting is the single most effective thing you can do to slow COPD progression and improve your symptoms. We have several tools. We have nicotine patches, one-on-one counseling, a support group that meets weekly. Would you be interested in any of those?
Yes, I'd like to try the patch.
Yeah, okay, great. I'll get that set up for you before you leave today. And are you still using your inhalers as we discussed at your last visit?
Yeah, I never miss it. I put them right on my sink, so it's the first thing I do in the morning.
Perfect. That's good to hear. Do you have them with you?
Yeah, they're in my bag.
If you wouldn't mind, just get them out for me and we can make sure you're using them correctly.
Oh, okay, sure.
Hello, I'm Dr. Nick Hanania. I'm professor of medicine and director of the Airway Clinical Research Center at Baylor College of Medicine and chief of pulmonary critical care and sleep medicine at Bentop Hospital in Houston, Texas. Welcome to this program entitled Breathing New Life into COPD, Empowering Patients Through Therapy Innovation. So as we just saw in the last scene, Saudi's COPD is giving her trouble. She's obviously not well controlled regarding her symptoms, despite being, at least what she tells us, on inhaled triple therapy already. She's still more breathless. She's coughing more. She reports 2 exacerbations in the last year, which really raises eyebrows. She's needing oral steroid for these episodes. Her symptoms now are impacting her day-to-day activity and work. And this is not unusual when you see patients with COPD who, despite adequate therapy, continue to have symptoms. And indeed, the importance of recognizing the burden of COPD in our patients is very, very important. One has to keep in mind that patients undermine their symptoms. And so it's very important to question them about how much can they do. Are they able to continue doing what they used to do? Did they have to cut down? All these are important questions. Of course, there are questionnaires to assess symptoms now, like the CAT questionnaire, the MRC dyspnea questionnaire. But persistent breathlessness limits everyday activity, may affect quality of life of these patients, like in your case. And not only that, but the mental well-being and the physical well-being are both affected. And obviously, these patients are at high risk of exacerbations, which may lead to emergency room visits, hospital admission, may need oral steroids and antibiotic therapy, and all that leads to accelerated lung function decline. And obviously, lung function decline can increase the risk of exacerbation, but these exacerbations also can increase risk of both cardiovascular events, but also depression, anxiety, and so on. So as you see, there is a vicious cycle that goes on in these patients who have uncontrolled symptoms, especially if they have a history of recurrent exacerbation. So when do we think about assessing therapy or rethinking therapy? The approach to COPD should be a multidisciplinary approach and in multimodality approach, including both pharmacologic and non-pharmacologic. But assessing appropriate symptoms by using questionnaires like CAT score or MRC score, asking the right questions, doing the right thing. The right thing is checking lung function as well. It's very important. Then, obviously, going through triggers. Smoking, for example, in her case, she continues to smoke. She exposed to secondhand smoke. She using her inhaler correctly. Reviewing inhaler technique is so important because many of my patients are already on inhalers and they're good inhalers, but they're not taking them correctly or they're not compliant with them. So I think these are very important to assess before you consider escalating therapy. Obviously, there are a few things that the GOLD and other treatment guidelines suggest is that we look at treatable traits when we approach patients with COPD. The, the two big traits are dyspnea as well as exacerbation. Obviously, this patient has both. She's short of breath, she has dyspnea, but she also has exacerbation. And the exacerbation, as I mentioned, impacts every aspect of the patient's life, quality of life, and may be associated with complications. One exacerbation will drive another one. Exacerbations may drive cardiovascular events. Of course, associated with exacerbation is airway inflammation, mucus plugging, and deterioration in quality of life. So all these are important when we assess patients who come to us who continue to have symptoms. But coming back to our patient, Sadi, we asked her to demonstrate her inhaler technique. And believe it or not, she does well. She's doing it correctly. So she is taking it. We checked her whether she's refilling her medication. She is. So let's go back to clinic and see what else can we learn about Sadi and her COPD.
It sounds like your COPD symptoms are still not fully controlled. So let's talk about what matters most to you. What can I do to help, and what are your expectations from your treatment?
Well, first, I really need to keep working. I can't afford to lose my job, and it's how I support my family. But at the same time, I want to feel well enough at home to do normal things, like playing with my grandkids.
Yeah. Well, I appreciate you sharing those priorities, and that's what we're going to aim for. Here's what I'd like to do next. Let's continue with your inhalers, both the maintenance one and the short acting. I want you to work on quitting smoking. In the meantime, I'm going to order some tests to see if there's more to why your symptoms are not well controlled.
What kind of tests?
We'll need to do a breathing test to see how your lungs are doing. We haven't checked that in the last year. And we'll also do a blood test to see if you have markers for specific types of inflammation. And we can use those tests to see if you may be a candidate for other treatments.
Okay.
I'd also like to refer you to pulmonary rehab. And that's a supervised exercise and education course that can build your endurance. So walking at work or at home becomes easier.
So kind of like physical therapy for my lungs?
Exactly.
Yeah, that sounds good.
Okay, great. So we've got our plan of action. Do you have any other questions for me?
No, I don't think so.
Great. Okay, let's plan to follow up in about 6 weeks to see how you're doing and what our next steps are going to be.
So, identifying patients who need adjustment of treatment is very important as a clinician, whether you're in primary care or if you're a pulmonologist or in specialty care. Obviously, one of the very important things to recognize is uncontrolled COPD, characterized by increased symptoms, but also history of exacerbations. More than a third of patients who have exacerbations don't report it to us, so we have to be proactive about it. And patients, when you tell them exacerbation, they may not understand what you're talking about. So flare up is another term they use. Sometimes patients say, I've had an episode of bronchitis. It's important to ask whether they needed steroids, antibiotics, emergency room visits, or hospital admission for their COPD. It's also important to ask whether their cough is changed, their sputum amount is changed or changed in color, their shortness of breath, they're waking up at night, whether they are more fatigued. And importantly, in the clinic, it's important to also look at their lung function. Although it's not the only thing, but lung function, as we know, is helpful in staging the disease. But it's also important on a serial basis, like once a year, to check lung function to see if a patient has lung function decline. Now, there are other tools that we can utilize in our clinic. One is questionnaires. We mentioned MIC dyspnea questionnaire. We also mentioned the CAT questionnaire, but we also can measure exercise tolerance by doing 6-minute walk test and see how much distance the patient can walk. We can also check their oxygen during the walk, see if they desaturate. Also, biomarkers are important. Although we don't have many of them, blood eosinophils tend to be a very important biomarker that we are now checking on patients with COPD, particularly patients like our patient here. Blood eosinophils can actually be predictive of increased risk of exacerbation. If they're elevated, they can also predict response to certain treatment like inhaled corticosteroids, but also it can predict increased readmission and admission to hospital, but also can predict response to certain treatments like biologics that are approved for type 2 inflammation. Before we go back to the clinic, let's review Sadi's test results, which just came back. So we checked her blood eosinophils, and current blood eosinophil while off prednisone, off steroids, was 320 cells per cubic liter. Reminder, a year ago, her blood eosinophil was 200. So she has persistently high eosinophils, which helps us in a way defining the endotype we're dealing with, the type 2 inflammation that she has. Her MRC dyspnea scale is 3, and her CAT score is 22, which means that the patient is quite symptomatic. When we did the 6-minute walk test, she couldn't complete more than 150 meters before stopping, but she did not desaturate. Her oxygen saturation remained above 90. Her lung function test, her FEV1 now is 55% compared to 62% a year ago. So there's no question that her lung function is getting worse. And that certainly is also very concerning. Now, in the next scene, Sadi comes back after 6 weeks for follow-up to discuss the test results. And let's join the conversation and see what the next steps for Sadi will be.
So, Sadie, I wanted to review your test results with you. Your lung function has worsened compared to your previous results from 1 year ago, and your labs show an increase in white blood cells called eosinophils. Now, in COPD, when your eosinophils are high, it means you have a subtype of COPD that may respond to some new therapies called biologics.
Oh, okay. What exactly are these biologics?
These are targeted medications that block specific inflammatory pathways in COPD. They're for patients with frequent exacerbations or flare-ups and elevated blood eosinophil counts, such as yourself.
Okay. And will these help me breathe better?
Yes, studies have shown that they can significantly reduce flare-ups and improve breathing, and by doing this, they lower your risk of further lung function decline or your need for more steroids.
And are these safe?
Yes, they've been studied extensively, and they are safe.
Okay, that's good. And so I can just stop using my other inhalers since they're not working?
Well, no, you do need to keep using those. They are still important in the management of your symptoms.
Okay. And how will I know if these are working? Will my breathing just get better once I start taking this new medicine?
No, these medications require ongoing injections that ease your symptoms by reducing inflammation over time. So you might notice a very gradual improvement rather than feeling better all at once. We typically wait 3 or 4 months to see how you respond, and then we reassess.
Wait, these are injections?
Yes, these are injectables. These medications all use auto-injectors, which look more like pens than syringes. But anyway, if you decide to move forward with one of these, we'll show you how to use them.
Okay, I don't know. This is so different from what I'm used to.
I get it. That's absolutely fine. You don't have to make any decisions right now. Let me go through some of the different options, give you more information about these medications, and then you can go home and think about it.
I'd appreciate that. Thank you.
You got it. Now, as I said earlier,
Now, we know that there are at least three types of inflammation in the airways of COPD patients. The most common is type 1, type 3, that is associated with neutrophilic inflammation. But about 20 to 40% of patients with COPD have what our patient has, type 2 COPD with high eosinophils. And that's usually the patients that we can actually identify by measuring blood eosinophils and sputum eosinophil if you're doing sputum induction. Now, Gold and other studies now have shown that blood eosinophils, as I mentioned earlier, are good predictors of exacerbators. Like higher eosinophil, the higher risk of they're prognostic biomarker, but they're also predictive biomarkers. The higher eosinophil, the better response to inhaled corticosteroids, but in general, we try to avoid using systemic steroids in these patients on a chronic basis because of side effects. So we talking about phenotypes of COPD is very important, and that's what the clinical presentation is. This patient has cough and sputum. Obviously, she has chronic bronchitis phenotype, but she also has a frequent exacerbator phenotype. That's well and good. But now we also look at what type of endotype does she have. The endotype really reflects what mechanism of the disease is. And for that, you need to look more in depth, looking at biomarkers. And here we looked at blood eosinophils, and certainly this patient looks like she has type 2 COPD. And that's important to identify early on so that we can, pick the right treatment for the right person. And in the era of precision medicine, this is so important that we cannot think that COPD is a one size fits all disease after all. Why is that important? Because we now have several new biologics. Two are approved by Food and Drug Administration for COPD for patients like Saudi who has history of exacerbation despite being on triple inhaled therapy, despite being compliant and adherent and uses her inhaler correctly, who has persistent high eosinophils. The first drug approved was dupilumab, which targets an interleukin 4 receptor, common receptor for IL-4 and IL-13. These are important type 2 cytokines. Patients who may respond to this drug are those with recurrent exacerbation, despite being on triple therapy, who have blood eosinophil more than 300 cells per cubic liter and history of exacerbation. Now, there are two large studies, the Boreas and Notice studies, that showed about 31% when you look at both studies, reduction in exacerbation in patients with COPD, very similar to our patient Saudi. Not only that, but in these studies, was improvement in symptoms, lung function, and quality of life with no signal of any safety issues, at least in the 1 year of the study. The second one is called mepolizumab, which is an anti-IL-5. It targets IL-5 cytokine, another important type 2 cytokine. This mepolizumab has been studied in three large trials. One is the METRIX and METRIO, where they looked at COPD patients with history of exacerbation where the blood eosinophils in one study more than 150. And it showed that these two studies gave us an idea that the higher the eosinophil, the better response to anti-IL-5. Finally, matinee study, which was published this year, showed that mepolizumab reduces exacerbation in patients with COPD whose eosinophil count is more than 300 cells per cubic liter who continue to have exacerbation despite triple therapy. And similarly, this was a 2 year study. Over the 2 years, there was no signal of safety issues in that population in the clinical trial. It's not the end of the story. Now, in the era of precision medicine, we have several new biologics being studied. They're all in development. So, whether they will be approved or not, it's hard to tell. There are biologics that are targeting the epithelial cytokines, which we call alarmins. These include uh, TSLP, IL-33, and the receptor for IL-33, which is the ST2. These biologics are still in phase 3 trials. In addition, benralizumab, which is an anti-IL-5 receptor, is also being studied in clinical trial for patients with COPD and recurrent exacerbation. So, in summary, increasing data show that eosinophils and airway inflammation and eosinophilic inflammation encourage a treatable trait approach to this COPD, especially in those patients who continue to exacerbate despite being on standard of care therapy. And therefore, treatable trait approach and in measuring biomarkers such as eosinophil are very important and are pivotal in the context of precision medicine and where we go to treat patients in the future. Thank you for joining me today in this Medscape clinic. I hope you have found the information presented here valuable to your practice. Please continue on to answer the questions that follow and complete the evaluation. Thank you so much.